Exactly. All right, so we have had an absolutely terrific day and a half, and we thought that maybe the best way to kind of wrap up, given how intense we knew it would be to ask a number of our esteemed planning committee members to join us here and provide their observations, having been here with us all along the way and having been part of the discussions that really had a substantive role in shaping the agenda. So I have up here with me first Mark Gorman, who is a patient advocate and a cancer survivor. Many of you know him from his leadership role at the National Coalition for Cancer Survivorship. We have Art Levin from the Center for Medical Consumers. We have Sue Sheridan from PCORI, and we have Terry Adirim from the Health Resources and Services Administration, or HRSA. So I've asked you guys to kind of go, give a 2-minute snapshot, key takeaways, whatever it is that you'd like to say, and then we'll have a little back and forth. So let's start with Mark.
I have a few talking points that I put together last night, which I'll get to in 1 second, and I'll be very close to my 2-minute limit here. But I'm trying still to wrap my head around a lot of what David Goodhill had to say. And I think one point that is buried in there is I think I hear him saying that the status quo, which nobody's happy with, depends a lot on an assumption that the patients, who are supposedly the principal beneficiaries of the healthcare enterprise, are at some level just incapable of being able to fend for themselves. So we have the intermediaries in the insurance industry that have built up, and all kinds of other people trying to protect us from harm being done to us. And that does need to be challenged, and I think that's actually a central theme that we're trying to get at today. Now, other observations that I think are worth sharing. I was taken by the 3-level framework for engagement that was just mentioned at the beginning of the meeting yesterday, that's in the policy brief from Health Affairs, and that was in the materials. And then there's another, I guess, longer paper, which maybe actually you guys can dig out and make available to us. It's been referred to as well. And in cancer advocacy, this sort of 3-level, what we've referred to as an advocacy continuum, was described by Ellen Stovall and Elizabeth Clark in 1996, and has been used by those of us in cancer patient advocacy extensively ever since then. We've used slightly different kind of language, though, which I think is very helpful to insert here. We've talked about personal or self-advocacy on one end of this advocacy continuum, community advocacy in the middle, and then public interest or policy advocacy on sort of the other end of the continuum. My observation, working with cancer survivors over close to a dozen years now, is that individuals can actually evolve along that continuum. And I think this was implicit in this paper. I've learned from doing policy or public interest advocacy training with cancer survivors and their families over the years that initially the word advocacy and this whole language of advocacy is kind of off-putting to them, until I explained to them how they've always been, in order to navigate healthcare successfully in the cancer context, effective self-advocates. Then they start to warm up to the idea. But the skills in being an effective self-advocate are actually transferable skills to being effective as an advocate for the patient perspective in the public interest arena. It's just, you need to learn how to be able to frame the context of your experience and story differently. Instead of trying to get good care in your immediate clinical encounter, you're trying to use your experience to policymakers and not just legislators. So that's one point. Another point I think is important to make is that let's not hope for too much of an outcome from one particular element of patient engagement. I refer you all to Dr. Berwick's paper on the wedges for dealing with waste, I think he called it, which was published in JAMA at the end of April of last year. And he cites failures of care delivery, failure of coordination, overtreatment, which we've spent a lot of time talking about here, administrative complexity, pricing failures. We heard a whole talk about pricing failures and fraud and abuse cumulatively as driving the problems with healthcare costs. The kind of patient engagement we've been talking about here can be helpful in the clinical encounter, but we can't solve all these problems there. However, getting back to my idea of the advocacy continuum or the stages of evolving patient engagement, and as Kristen just explained to us from her own stories, experience, people become motivatable to become advocates on the policy or public interest aspect of trying to deal with healthcare problems as a result of their need, oftentimes, to become effective advocates on their own behalf. So I'll stop there. I had like one more paragraph, but maybe I'll insert it another time.
So I've got 20 pages of handwritten notes sitting here. I want to assure you that there's going to be, I think, a report of the workshop. So I feel that'll be your opportunity to sort of review the details. So I'm going to talk a little bit about strategy and politics. Right. So about strategy and politics. So I think we would all agree that what we talked about during this day and a half is complex. It's difficult politically and culturally. We heard that culture eats strategy for lunch. Maybe. I think if you're a good strategist, you need to take that into account. Maybe you can bite it back. I think we're in an era where people are struggling to keep their heads above water in all aspects of their life. And I mean as patients, as families, as caregivers, as clinicians, as CEO of hospitals, of people running rehabs and long-term care. These are difficult, difficult times politically, economically, a lot of uncertainty. And we're dealing with a sector that is probably the most resistant to change of any I know. So we've got a sort of difficult job ahead of us. So I think we have to be careful about how big a boat we're trying to float at any one time here. We have to really get to be strategic and political in how we think about it. So I would suggest, and I'm not going to ask Michael to sponsor it, but he might, to convene a priority setting exercise, hopefully driven by the people we've been focused on, patients, families, and caregivers. I always want to put caregivers in because some people don't have family members as caregivers. They have friends and others. I think we need to think about what's the most important place, and by the we, I mean the bigger we, the royal we. Where do we need to begin? What's the most urgent? And then we sort of need to create another grid, which is what's the most attainable? What do we think would be we'd have the best chance of getting? And then crosswalk those and see if we can come up with 1 or 2 wins, potentially, in a short term, that would get us along the pathway. I think we need to always be cognizant of the barriers. We need to evaluate what the barriers are and how difficult it is to change. We all agree we need payment reform. Do we really think we're going to get to that payment reform nirvana tomorrow? I don't think so. I think there's a long battle ahead of us. We need to argue that engagement is not, I would argue that engagement is not a theoretical exercise, that we must present real and practical values and benefits to what we're suggesting. And let me just give you a quick analogy. I've argued with efforts to educate the public about the benefits to them of HIT and HIE that we don't have much to show them. We're asking them to enter into a social contract to give us their data and for us to use it, and we're sort of promising that their care is going to get better, and the handoffs will be, care court. It's very hard to demonstrate that. So I think we have, in sort of creating this priority list, we have to think about where can we really deliver? Where can we, get, to use Ken's word, the hook? Where can we really say to patients, we promise you this and we're going to deliver it the next year to you, and you're going to see the value of what we're talking about a learning healthcare system and shared decision. You're going to see real value there. Lastly, the one thing I worry about with, and I think somebody else has mentioned this, that we're spending tens of billions of dollars on health information technology and exchange. I don't see very much attempt to integrate patients, families, and caregivers into the process, other than give them a portal and let them look at their lab values. I think we need to be thinking far differently about that. One, they should be in at the ground floor. Problem because vendors don't even have clinicians in at the ground floor, which is one of the problems with the product. But we really need to have that community of patients, families, consumers, whatever we want to call them, caregivers, really engaged in this. And we have to design a system that meets their needs. And maybe patient portal and looking at lab values is good for some people. It might not be the priority of some other people. I don't think we understand what is, but I worry that the horse will be out of the barn. We'll have spent tens of billions of dollars on a system which doesn't even begin to deal with the concerns that we've been talking about for the last day and a half.
Okay, guess I can go next. Hi. I'm Terry Adirim. As was said, I'm from the Department of Health and Human Services, the Health Resources and Services Administration. We serve the underserved, and I had the great pleasure of being on this planning committee. I want to thank you for including me. I learned so much from my colleagues, and I've learned so much from all of you in the last day and a half. My remarks are very brief, and they're centered around just repeating what I heard were the barriers to achieving partnering with patients to drive shared decision making. And then to also, I heard some approaches and solutions that came from our speakers. So I thought I would just take a minute to do that. I will say that healthcare is transforming so quickly. Just the other day, I got a mammogram, and I got the results before my doctor did, which I thought was kind of amusing. So there's a lot of things that even myself as a physician for the last 22 years have noted that there's a lot of change, and this is an opportunity, I think, for all of us to impact the way medicine is practiced going forward. And I think listening to all the patients over the last day and a half really gives me a sense of urgency to do this, and I really appreciated hearing everybody's stories. So what I heard over the last day and a half, that some of the barriers to achieving what we're trying to all achieve is that we're still seeing within patients some passivity with regard to their health care, that there's a culture, a top-down authoritative culture within the medical profession. Both physicians and other practitioners. In fact, one of my seatmate was telling me about one of her experiences in the emergency department where a nurse authoritatively told her something, and like, who is she? And I agreed with her, even though I am an emergency physician. The other thing that I heard articulated too is that there's a skills gap for both practitioners and patients with regard to all of what we've been talking about. There's also a barrier with regard to access to information, and a lot of them, as my colleagues have articulated, are technological challenges that I think we need to overcome. Also, this is not a system, and I hesitate to call this a healthcare system. It's not really a system, but it's not really oriented to patients. It's really focused, and I'll be the first to say as a physician, it's really about the practitioners and what's easiest and best for us. And so until we change that culture, it's going to be very difficult to make the changes that we're looking for. I think, too, there are real or perceived external pressures on us as practitioners. There's, as everybody's talked about enough for the last day and a half, payment structure. There's time pressures as well. And there's also regulatory and policy issues, including the way we interpret these regulations and policies that are real barriers to being able to get to where we want to go. With regard to solutions, what I've heard from all of you is that we really need a multi-pronged, multidisciplinary approach. And what I took away from our keynote really is that we can learn a lot from people outside of medicine and people in other industries. Even though I didn't agree with some of what he had to say, I do think it's useful. And I know myself personally, I've just finished training in Six Sigma, and there's so much with regard to the manufacturing industry and other industries that we in medicine can learn from. So I think that's an important thing we need to bring other people to the table. So I think, too, yesterday somebody mentioned that some of the issues could be ameliorated through a systems engineering approach, and I wholeheartedly agree with that. I know some people didn't agree with that, but we really need to change the focus on patient needs. Even things on when and where patients get their treatment. Who said that you have to go to the doctor's office to get your treatment? Who said, and I'm speaking as an emergency physician, that primary care must be doled out Monday through Friday, 9 to 5? So even just engineering the system so that it's more patient-focused, it would be something to move towards. I heard a lot of physician and patient blaming language, and I caution people from blaming any people about this, because one thing I learned about from Six Sigma is that what's most important is the voice of the customer or the voice of the patient, but also it's the process, not the people. So I think we really need to spend a lot more time focusing on the process. I think, too, as I mentioned, we really need to address competency development and training. We really need to look at where we're training our healthcare providers, how we're training them, the structure. And we are moving more towards team-based approaches. And I know at my agency, a lot of the funding for healthcare is moving to interdisciplinary kind of care. So we're moving in that direction. We need to keep pushing that. We heard yesterday, especially, organic local demonstrations, and I think they were fabulous, they were wonderful. But the solutions that we need with regard to those is how do we determine which is best, and how do we bring these to scale? So those are some areas that we should look to. I think, too, listening today to our speakers, that we need a new research paradigm. Emerging is a more inclusive of patients type approach, and I think that's really good, especially when it comes to governance, contributing of data, use of data, and the giving back to patients who participate. And I think technology and social media, and that's what I heard from this morning, are very important. I think, too, transparency in a lot of ways was a running theme over the last day and a half with regard to research. And I think in some of that there may need to be some regulatory fixes. But I think, too, with regard to the economic-based solutions, I think there's something, even though I didn't quite agree with our keynote, I think there's something to be said to actually seeing how much our care costs. And the Time article that came out recently made a huge impression on me with regard to that. I think, though, we need to be careful with regard to economics, because I truly believe healthcare is not a commodity like other commodities or like my iPad. Everybody needs it. Everybody's going to have it. And we in this society believe that we're entitled to it. So I believe there's a different economics with regard to that, but we could still learn from other industries. Let me see. I think we need to engage our funders and academic institutions to change or modify how researchers are evaluated, promoted, and funded, because those would be the motivators to change how we engage patients in research. And again, transparency is very important. So I think I've said enough.
Great. Well, that's a nice segue for me. It's been fascinating for me to participate in this because I wear two hats. I am the Director of Patient Engagement at PCORI, a research institute, Patient-Centered Outcomes Research Institute, but I also wear the hat of a mom. like Kristen, I have a son who's a young man who has cerebral palsy, multiple disabilities. We are frequent flyers in the healthcare system, and his condition was caused by newborn jaundice 17 years ago that was completely preventable. I also speak as a widow. I speak as a widow where my husband, Pat, died 12 years ago of cancer, and it was a cancer that was diagnosed properly, but the pathology got lost for 6 months, and it was not communicated. So I listened the past 2 days through the patient lens and also the research lens. And it's a lovely combination. You know, PCORI is about the perspective, the wisdom, the outcomes of the patient population. When I say patient, caregivers, family members, advocates, combining that with rigorous research. And we think that that is going to be the kind of science that drives change. And so what I walk away with today is hope. I'm aware of barriers. I'm aware of, government challenges. I'm aware of costs. But 10 years ago, there wouldn't have been patients in this room. And today, we have patients in this room. And we have a lot of patients in this room. And I want to thank Dave and Kelly and Perry and Kristen and Greg and Ronnie and Linda and all of the, we are here because of you. And you are our teachers. And we're both teachers and learners, so you gave us vision today, and this is important for us to focus on vision and hope. So what I heard today, sorry, I have to put my glasses on. I heard today that, and I'm sorry if I don't remember your names, but to listen what patients are clamoring for. I love that, because we are clamoring. And I heard that we want to be safe. We want to be informed. We want to be empowered. We want compassion. We want to survive. We want outcomes that we decide, and we want quality of life, amongst many other things. And I think addressing some of these challenges that we have, if we keep this paramount, I think we can make a difference. So Greg Biggers mentioned the new we, and I love that. Thank you, Greg. And we're talking about a new we. Sally talked about a patient-powered network, which I think is really important to think about. Patients are powerful. Our data is powerful. Our experiences are powerful. So something that was described earlier today is that, and I suffered this when I was a patient advocate. We wanted change, and we wanted it fast. So we demanded solutions from the Joint Commission and from NIH and from CDC and from researchers who partnered with us, and they said, hang on, good solution, but we need evidence. So we backed up a little bit, and we joined researchers, and we developed the evidence, and we gave it to CDC, and we gave it to the Joint Commission, and we gave it to those who regulate and create protocols for our country. And we saw change. It took us 8 years, but it happened. It happened in partnership. It happened in partnership with HHS, with researchers, with parents, and those parents drove that change. So what I'm seeing is coming from the research world at PCORI, we are bringing patients in, and we're still learning, and we want you to help us. We're trying to infuse patients at every step of research. And so we're inviting patients to submit research questions. Tell us what's missing. Tell us what you need us to research based on you and your life and your challenges, and what information is missing. We're bringing patients in, and we're training them. We have patients who are sitting at the table with scientists reviewing proposals and deciding what PCORI funds through their lens. We're bringing patients in to help, when we have research results, disseminate. Traditionally, research goes into peer-reviewed journals. Moms and dads and patients typically don't read those. How do we find these creative pathways? Bringing the patients in to help us do that. And then how do we evaluate ourselves? We want the patient population and caregivers and stakeholders, we want clinicians to tell us how are we doing and how can we do this better. So we're creating an infrastructure right now, bringing people in as much as possible as we can. We're going to be impaneling a patient engagement advisory panel in about 6 weeks to help guide us, make sure we are patient-centered, we are engaging patients every step of the way. So what I'm hearing and feeling is, over the past 12 years as a patient advocate, activist, whatever we call ourselves, we were pushing. We are pushing for change. We are calling for change. We're pushing. I'm seeing a shift now where we are going to be pulling for change. We're going to be in front. We're pulling along the system with us as partners. And that's a difference. And I see that pull effect going on with these discussions. So in conclusion, I think that we have an opportunity. We have an opportunity to make a difference in patient lives by really bringing in the patient voice at every step of the way, whether it's research, whether it's as a patient themselves, if it's in policy making, if it's at the institutional level. Let's look for every avenue we can plug the patients in. Peter Margolis said, and what if? Consider the what if. What if we did this? What if we had patient-powered networks and patients sitting on QIs and IRBs and in research? What if? And that's what I invite you to envision. I challenge you and I invite you. And I think that collectively we can make a difference. Thank you.
Thank you. So I have 3 questions, one in each of the areas that we talked about. I probably have 500, but I've tried to narrow it down to 3 so that whoever feels like taking a shot at it could. So the first is in shared decision making. We heard from Gary Langer that 80%, more than 80% of patients would like to have shared decision making. We know from actually the research that Teresa talked about earlier that my organization asked them to do. We tested the idea of shared decision making in juxtaposition to some other health reforms like payment reform and IT and patient-centered medical home. And it wasn't particularly compelling because everybody said, well, that's just a fundamental right. Right? So we have, I think, a situation where there's a lot of openness and willingness to engage from patients. So I guess my question is what you guys sort of think the holdup is, because I'm not sure that it's consumers on this. As we think about a pathway forward for shared decision making, where do we start?
I have to do a disclaimer. I'm on the board of the Foundation for Informed Medical Decisions, so I just want to make that clear. I think shared decision making is important. I think we're talking about a democratic process. And it sort of philosophically, I see this as democracy. And in my more than 30 years of advocacy, talking about the need for giving patients and families and caregivers the information they need to make informed choices before it was ever a foundation, I just saw that as basic democracy. And if you go back to when I started, we lived in a really closed world. There was one medical reporter, Larry Altman of the New York Times, who was an MD. There was nobody else around. If you wanted to look at the PDR, it wasn't in Barnes & Noble. You only got it if you were a practitioner. You couldn't get into a medical library. You could get into regional medical libraries like Library of Medicine, but it was a nightmare to get through it. So there was really the control of information. That's the opposite of a democratic state, right? And so I always thought of it as a sort of basic principle that in a democracy we needed to share information. There's also, and I've forgotten the name of the report, although Michael may remember it, in 1982 there was a President's report, Commission on Biomedical, long name, and there was one chapter of that, which is one book, on autonomy, self-autonomy and decision-making. And this is going way back. So they probably did this study in the 80s, and they asked people from various backgrounds, demographics, do you want information so that you can make a more informed choice? And the vast majority said yes. And this was in an era when there was no information. So I think that longing for information, that longing for participation has been around for a long time. The other thing is, if we really believe in informed consent as an ethical and medical imperative, how do you give informed consent if you don't have any information? You're just signing a piece of paper, which is mostly what happens now. It's a sham. People are not really giving informed consent to whatever it is they're being asked to undergo. So I really think shared decision-making is a critical point. I think there are ways out there where people are experimenting. Washington State, for example, you can imagine mandating. You can imagine payers saying, we're going to pay more or we're not going to pay, unless there's some documentation that's reliable that there's a shared decision-making process. So I think that may be one of the priorities. in the sense that we sort of understand it well. We have a lot of evidence about its effect and effectiveness, and that it's probably doable. It's not easy, but it's probably doable. We have lots of examples around the country of where people have done this successfully, either through mandates or on their own initiative or through grant programs. So it'd be a good place to begin.
Something I think that in terms of shared decision-making and participation, I was at the WHO for 7 years working with patients all over the world, and the WHO did a survey on outcomes, and if patients wanted to participate in assuring their own outcomes. And so we sent out a survey, got a response from 59 countries, and the overwhelming answer was yes. We want to participate. Didn't matter the culture, the country, the government, the economic status, yes. And then we said, what do you need to participate? And the answer was an invitation. And so have we, as a healthcare system, appropriately invited our patients and caregivers to participate in improving good outcomes? It was a simple response by the patient population globally, and the WHO honestly thought it was one of the sexiest pieces of surveys that they've ever done, because it was so simple that it was overlooked prior to this. And so I ask, are our clinicians, are our hospitals, are our systems, is our government, are we, extending that invitation to come participate with us?
So I think that's actually a good segue into a question about value. I thought the sessions today were really phenomenal, but they pointed to a real tension point for me. So on the one side, we had, and Chuck Alston has a great slide on this, where he says value, V-A-L-U, is a four-letter word for patients, right, for consumers. And we heard a lot about why that is today. And we heard Marge Ginsburg talk about the need for more public deliberation and how do we shift expectations. In fact, that was the title of the session, was, changing expectations. On the other hand, we heard from Dave DeBronkart, and this has been my experience as well, and we heard from a couple of other folks in the room, that when they were all ginned up to go, get the cost information, to find the high value providers, because clearly they had either deliberated their way there or they had a high deductible health plan. What we found was that the system was absolutely ill-equipped to give it to them, right? So not only, so on the one hand, it feels to me like we want to invite patients to engage in this discussion about value and cost and quality. And on the other hand, when they accept the invitation, we go, oh, no, over there, you over there. We're not ready for it, right? So I think what, Dave also used sort of that four-part hierarchy of data, information, knowledge, and wisdom. And so if we think about that, I don't even know where on the spectrum we're at with respect to cost information. We're not at the knowledge part. We know that. So that's what I want to know, right? That's what I want to know. Are we even at the data part? How do we move forward?
I would say we're not at all. No, for most of the last year, I've been branching out in my life as a patient advocate. I've spent a lot of time in Texas with my 92-year-old mother, who's in good spirits, but has a lot of things going on. And last May, she was in hospital for a month. I mean, part of that was necessary, but when the summary came from Medicare, and I added up all the putative charges, it was close to $500,000. And what David was talking about before, there's virtually no honest pricing information available. So, pricing is completely failed. I mean, that's what Dr. Berwick's talking about as one of the problems. Pricing has completely failed to send signals that are meaningful to patients in any role as buyers, except, we're starting to get some and maybe more on high deductible plans. But even there, I think people are going to end up sort of in one-off negotiations at the time of service and the point of service with, you know, the provider that they're talking to, with an eye towards, you know, what is going to be the impact on the deductible. I mean, it's not going to be market-based decision-making.
So, excuse my ignorance on this, but I like to ask people at the table and out there, is there any evidence that giving people costs, as we now, you know, with all of their warts right now, makes any difference? Because if we're all about evidence-based.
Arthur, what we found was we actually could be to give them the kind of information about costs that we have today. And that, I hate to tell you this, but a lot of people are already sharing this with consumers, including CMS.
So for those of you who couldn't hear, because poor Shoshana doesn't have a mic, although we should permanently maybe attach one to you, just checking, was that her work found that it actually could be dangerous to give consumers cost information. And I would say, I think you mean in this context in particular, in this healthcare system, my sense is that, and I'd love to know what you guys think, I mean, my sense is that what David Goldhill was really arguing was that if we open it up and actually, you know, forget giving them cost information, just make consumers responsible for bearing the cost, that the market will restructure itself. Now, I have to tell you, being of the age where there's a lot of people in this room who are probably going to be like on Medicare before, certainly before I will, but before this David Goldhill system comes about, I don't want to be caught in the middle. I got to tell you. So, I mean, what do you guys think about this idea that, well, let's just put the burden on them because in some period of time the market will restructure? Will it work?
I mean, there's no question that people are more sensitive to what they have to pay if they have to actually pay it out of pocket. I mean, I think that's like, you know, a no-brainer. Is that the right way to deal with health? Can we deal with all the other, you know, I mean, David was up there saying, of course, we'll deal with catastrophic illness, we'll deal with this, we'll deal with that. What are the assurances of that? I was glad to hear he was in favor of a national health program. Very nice. But you know, I think we really have to pilot that kind of idea to see what the risks are. I mean, we have a growing vulnerable population, not just by age, but by all kinds of disabilities and disease that require a lot of care. I know the 90-10, I mean, it's an interesting artifact. I think all the things he said are sort of fascinating challenges to the exceptionalism of healthcare. Whether the answer is to simply give all of us the $10,000 or the $15,000 to go out and buy our own care, I'm not sure, because I don't really know if we're ready to, if we can equip people with the information and the skill sets they need to make the right choices. I don't think we've been very successful in doing that, even without that challenging, you know, the challenge of, okay, you're going to pay for this out of your own pocket. So it isn't really a marketplace, right? We don't, if I know what a copier is supposed to do, so if you know, when a company makes a bad copier, it means I go to the copier and I push the button and it jams or it doesn't, you know, it doesn't produce a copier. I'm not sure we know if I break my knee what the outcome necessarily should be. I want to be better, but I don't know how much better it can be and stuff. It's a very different world, I think. I don't think you can make, just a transfer that this is just like any other business. It's like any other marketplace. It is in some respects, it isn't in others.
I agree with that because, you know, you can't, what happens is if you're responsible for paying for something which could have a huge impact on whether or not you have a good quality of life or live or die. I mean, you have people in certain age groups who will forego that care. I mean, it's been shown in studies that, you know, people of a certain age group, older, elderly, will give up whatever they have for younger generations. So that's why Social Security was created, so that we can take care of elderly people. I don't think healthcare runs by the same economics as, you know, our other commodities. So I think you have to be really careful. Now that said, I think he had an interesting point because there is a difference between, you know, emergency type care, critical care versus preventive care. So perhaps doing demonstrations or models where people would pay for routine care as opposed to, more catastrophic, what's now considered higher cost care, could be something to look at, and then develop that evidence that you're looking for, whether or not you can change people's behavior with regard to use of healthcare. But
Sue, no?
Well, this is maybe a bit Pollyanna-ish, but going back to patient engagement and having patients guiding change and research. And the reason why I say this, and that just the what if, Peter's what if we did, bring in patients at every level of research and solutions and systems and policymaking, could we expedite change? And could we expedite better healthcare and better outcomes? And the reason why I think this is because when I referenced what this mothers group in changing the standard of care for newborn jaundice, within 4 years after we started with our researchers and the system, Brent James from Intermountain Health and Hospital Corporation of America implemented the solution even before there was evidence, and they reduced readmissions, newborn readmissions by 30%. Somebody was saving money. And so I think the patient piece of driving change can be an expediter. Patients rarely give up. And honestly, the researchers that we've worked with said, the patients kept us on task and they kept us going when we were wearing out. But it was also the other way around. When the patients were getting worn out and frustrated, the researchers kept us going. And so can we use patients as a catalyst to expedite change that will help save us money? I know that's not a short-term solution, it's not the whole solution, but it's a part of a solution that I've witnessed that I think that it would be great to study. Oh, I know somebody who might be able to study that.
Oh, who might have the funding for it, huh? So a neurologist once told me that when you hear a new idea, it fires the same receptors as pain in your brain. So I was feeling a little bit of pain in David's presentation, but I don't want to dismiss it because I get the point, right? All it takes is the one doc practice who everybody suddenly realizes, oh, they'll see patients after hours. They post their prices on their website, right? We have little teeny examples here and there of people doing that. And I think it is really notable to point out what Tressa said and what Chuck Alston also said in his public comment about that for the first time, just in the last maybe year or two, they're really sensing some big, or maybe it's a deeper anger and frustration with cost issues, and that there may be kind of a change on the horizon. So I'll say before we wrap up, maybe we got the agenda order backwards. Maybe it has to be, the research pathway first to set the stage and provide the evidence for shared decision making, which is how we're going to get, right, ultimately to value. So, all right. So we're going to wrap up and turn it back to our host, Michael McGinnis here. But before we do that, any burning comments from our panel?
Just one comment I want to make. I think it's important to keep in mind that the rapidity of change right now, that we're in a world of rapid change. And a lot of what we've talked about is today and not about tomorrow. And so by tomorrow, what we talked about today will be out of date. And it's a new paradigm of thinking, that we really have to be thinking far down the road. We have to deal with today's problems, but we have to deal with tomorrow's problems even more. So we need to really always be doing that stretch. And as people have mentioned, we have a whole new generation coming up who doesn't have a laptop like I do or a desktop, but really a device in their pocket. And it's the way they get information. They're going out to a restaurant, they don't read a magazine, they look it up, get the rating. So we just have to bear in mind that the rapidity of change is overwhelming, and that we really have to sort of train ourselves to say, okay, we're thinking in today's world, and we really need to be thinking about what's tomorrow's world going to look like.
So I want to say two thank yous. One is to the planning committee members, not just those here up on the stage, but those in the audience. If you guys want to just stand so we can recognize everybody. This agenda was phenomenal. And I also want to say thank you to our host, the Institute of Medicine, and Michael McGinnis for his passion and commitment, and the staff for their support. We're very grateful for your interest in the topic. Thank you.